Yeah, live, please.
It's not sharing. Is it sharing?
So it's sharing, Doctor? Yes.
A very warm welcome and to iFocus Online Lecture 523, the 14th in Eye in Systemic Diseases. Today we have Dr. Pranesh Balasubramaniam from Moorfiels Eye Hospital, London, UK, to speak to us about eye in respiratory and gastrointestinal diseases. He's completed his MBBS from Coimbatore Medical College, did his MS at Arvind Eye Hospital and Postgraduate Institute, Madurai. He's done his clinical teaching fellowship at Moorfiels Eye Hospital, London, UK. He's pursuing his acute general and cataract fellow at Moorfiels Eye Hospital, London, UK. He is a trained cataract surgeon and has trained several other students at Arvind Eye Hospital, Coimbatore. He's an awardee of IOFF Fellow Award in 2021. He's a clinician trainer of the year in 2024, awarded by Barts London. Also the awardee of New Voices in Health Professionals Education 2024. He's the chief educator and the founder of our favorite King's Crux Ophthalmology Pearls, a well-known platform for postgraduates. He's a national expert on presentation skills and public speaking by the ophthalmic fraternity, and his primary interest lies in ophthalmic education, medical retina, uveitis, is extremely passionate about teaching using innovative tools, which you will get a glimpse of today, to provide free and quality ophthalmology content worldwide. He's also authored 3 self-published electronic books for ophthalmologists. Today's class would be made in a very interesting and innovative manner, and we can have no other than this man. Over to you, sir.
Thank you so much, Ashwita, for this introduction, and thank you so much, others, for joining today. So like what Ashwita was saying, this is going to be something different from what we normally have, just a different way of presenting. So I'm going to try and use mind maps to present the information. So let's see how that goes. So I would just want you guys to experience this. And if you have any queries, let me know. And if you have any comments or any feedback, please feel free. I'll be really happy to hear from you with regarding to the the presentation of this topic. Right. Let me share the screen. So as you can see, this is what I'm presenting. You should be seeing this big black thing, and you can see these colored boxes. This is a mind map, right? So what I want to do is, before I jump into it, I want to share this mind map with you before even I start this lecture, so that you can have that as a material where you can follow along. Yeah. So I just want to show you where you can get this mind map. So I know some of you might be watching this online, and some of you will be watching this recorded. But no matter what it is, you need to go to this website, this URL, bit.ly/m/Pranesh. So once you have typed it, you should go to this website, and there you have got these links of different resources. Please feel free to access them. And for our content, click on this interactive mind maps. When you click on that, it goes to this. And again, these are mind maps which I made for my students before. What will be useful would be this links for interactive mind maps. You click on that, it goes to these web links. And you click on this eye in GI/lung. And you click on that, it goes to the mind map, what I'm going to use to present now. So you can open and close the mind maps. You can't edit it, but it is collapsible and it kind of expandable, right? So it'll be more easy for you to understand the whole picture of eye and lung and GI diseases. So this is an experiment, but hopefully this should be useful compared to the routine PowerPoints what we are used to experience. Now, before again I start the presentation, I want to give some 2 useful materials. So you come to this interactive mind maps and you will see eye in GI diseases folder. Click on that folder and you will see 2 ebooks. Please make use of them. They are brilliant ebooks. One is the classic eye in systemic diseases. Forget about that one, but that's the eye in systemic disease by Professor Kansky. And this gives a very good description of the ocular problems, diseases in different conditions. A more recent one is this. The first ebook, Ocular Manifestations in Systemic Diseases. This is a very useful book as well, which has very similar structure, but it gives more information on the systemic diseases. Yeah. So I've attached these two ebooks, and these two ebooks should be good enough reference material.
Excuse me, sir. I'm sorry. Are you trying to show your screen where you're showing
Yeah.
all this? That's not
It's not.
actually seen. Only
All
the
right.
mind map was seen all this time.
Oh, okay. Sorry about that. I think I might have shared the
The other
entire,
screen.
just the mind map. Yeah, sorry. Uh, Windows. Right. Now is it shared? Yeah.
Yes, sir. Now we can see it.
Sorry about that. Yeah. So if you can, this is the website I was mentioning, bit.ly/m/Pranesh. So you go to that website, it goes to the link of, lots of links would have been put here. So you can take a photo of that, of this URL if you want. You can take a screenshot, or if you're watching recorded, please make a note of that. And then you click on this interactive mind maps, and that goes to this drive, right? And this drive will have these links of different PDFs of the mind maps. So you need to click on this one, the links for interactive mind maps, and that goes to this box. And then you have again these many web links. You click on this I in GI/lung, and that goes to this mind map, what I'll be presenting with you guys today. So you can open and you can close this mind map. Yeah. And you can follow along as I am explaining through branch by branch. That's one thing. The second thing is you come back to this interactive mind maps and you click on this I in GI diseases, and that goes to two ebooks. The first ebook is the classic book by Professor Kansky called The Eye in Systemic Disease. So this book has pictures and it has descriptions of the systemic manifestations of ocular diseases, or the ocular manifestations of systemic diseases. And this one, which is titled the same, right? This is a more modern textbook. This is what I use as a reference as well. So please feel free to download these ebooks. These are really useful, not just for this lecture, but as an adjunct reference material for your other similar lectures, where the other eminent speakers have talked about the systemic manifestations, systemic diseases involvement in the eye. All right. So with that, let me quickly jump to the mind map. Yeah. Hope this is visible now.
Yes, sir.
Yes, sir.
Fabulous. Great. So this is the topic given to me. And before I begin, thank you so much, Dr. Santosh Honavar, sir, and Dr. Partha Pratim, sir, for this opportunity. Two of my favorite educators. I'm really happy and I'm honored to be a speaker a second time this year. The topic is on eye in lung and GI diseases. And when this topic was given to me, I was not really sure the importance of the topic with regards to DNB exams or MS exams, because I know it's basically for postgraduates. If it is not for exams, don't worry. But what's more important is this topic and the other topics as well is relevant in one way: how a systemic problem can impact the eye, right? And it reinforces the point that eye is the window to the health and the soul of the body. And if you're going to be a practitioner, maybe in a multi-specialty hospital, you would understand the importance of having a sound knowledge of various ocular manifestations when you see a systemic disease. So I'm seeing this at Moorfiels, where I'm practicing in a multi-specialty hospital, a more acute trauma center, where patients will be sent to us having a lung cancer, having a inflammatory bowel disease, will be sent to us to rule out any ocular manifestations, which you might not see very often if you are an exclusive eye hospital. But you would see such scenarios more in a multi-specialty hospital, or in a more corporate setup, or in a medical college for that matter. Premier institutes like AIMS or JIPMER might have similar scenarios as well. So now you know the importance of this topic, the relevance of this topic. Let me just brief out what I'm going to discuss. So I'm going to discuss about three aspects. One, apart from the respiratory diseases and the GI diseases which cause eye problems, I want to bring about a common principle there. There is a reason why Partha Pratim sir has given this topic, or Santosh has given this topic, eye in lung and GI diseases, because there is a commonality, there is a common ground between the eye, lung, and the GIT. And that is explained by this immunological frameworks. As you can see in the picture what I've drawn, here we have the eye, that's the lung, and that's the gut. You can see there's connection between the eye and the lung and the eye and the GIT, which is explained by a very recent advancement called as the lung eye axis and gut eye axis, which will be really helpful to put in your exam papers if this question was asked. So when it comes to lung eye axis, what it means is that there is a lot of similarity between the lung and the eye and the GIT as well. When it comes to this mucosal setup, when it comes to immunological frameworks, lots of similarities there. As you can see in this picture, an inflammation in the lung, right, can impact the eyes, right? A very classic example would be an allergic conjunctivitis and asthma. So patient who's having an allergic conjunctivitis, most often they would have an atopy, they would have an underlying systemic allergic condition. So that's a classic example of where the eye and the lung are connected. And also you know that a patient who's going to have a flu and viral infection involving the lungs, URTI, can have an ocular involvement as an acute conjunctivitis as well. It's another classic exam questions, viva questions, which they can ask you. So understanding this is important, the lung-eye axis. Similarly is the gut-eye axis. When I mean gut-eye axis, again, it means that there is a link between the GIT and the eye. So one way is this. Look at this picture, what I've drawn. Molecular mimicry, which means, as I just mentioned, both these systems, the ocular system and the GIT and the respiratory system, they have a commonly shared immunological framework. For example, in the gut, you have this gut-associated lymphoid tissue, and you have this eye-associated lymphoid tissues, and both have similar features. So what happens when you have these inflammatory cells, sometimes they find similar or mimicking features between the two areas. So when you have these triggered T cells or all this triggered or hyperactive immune reaction is happening, it starts to fire at both the end because they don't see a difference. A very useful concept in this gut-eye axis is this. See, you have a microbe which is attacking the gut, okay? And now the gut is suffering. The GIT is suffering. Now these immune cells starts to attack the gut itself. That is what we call as an autoimmune response, an exaggerated response, where the abnormal cell is detecting a self-antigen, starts to attack our own body, right? So what happens then? You have this blood-intestinal barrier, and that gets breached because of inflammation. And now these cells are going to travel through the blood vessels, and it's going to reach the eye, and it starts to fire, it starts to attack the eye as well. So this trigger, the micro is going to be an important trigger. This external pathogen is going to be a trigger. In fact, most of the autoimmune diseases, if you're going to look into research, they would have an underlying infective pathology. Some sort of a trigger would happen, which kind of triggers this inflammatory cascade. So you have to understand this important feature of a breach in the blood-intestinal barrier. And because of that, what happens is immune cells are getting trafficked from or kidnapped from the GIT all the way to the eye. So first is going to be the molecular mimicry, and second is going to be the aberrant immune cell trafficking. The third concept in this gut-eye axis is this gut dysbiosis. These are all very recent papers. A gut dysbiosis means biosis. So we all know that there is a good healthy bacteria in the gut. And because of this inflammation happening, there is a derangement in this balance between good and the bad bacteria. This is called a dysbiosis. So a disruption of a healthy microbiome. And studies have shown that this dysbiosis is directly relevant to causing various ocular diseases, such as dry eye disease, such as you can see in this picture, a big list of conditions, uveitis as well. So it's very relevant in uveitis because they're now targeting treatment to treat this intestinal microbiota, to targeted treatment with regards to this dysbiosis, to treat uveitis, right? Just like how we give an oral steroid to control inflammation of the eye, we are targeting these organisms, or we are trying to bring about a homeostasis, bring about a balance between the good and the bad bacteria, so as to bring down the inflammation in the eye. So this is gut-eye axis. So now we know the lung-eye axis, and now we know the gut-eye axis. These two are going to be the common principles, or it's going to be the immunological pathophysiology with regards to eye in GI and lung diseases. So we have finished this part. Now let's go on to first respiratory diseases. Now, my goal is not to explain about each and every disease what you see in detail. For example, in respiratory diseases, I've classified this into different diseases, and one of them is a systemic inflammation. And there you have sarcoid. So I have not explained sarcoid in detail. I know that there's another lecture just on sarcoidosis, but my goal is just to give you a framework of how to answer these questions if they ask in your exams. So if it's a respiratory diseases, systemic inflammation, infection, genetic, local, and treatment related, you can classify accordingly. Systemic inflammation, the archetype, the prototype inflammation is the sarcoidosis. So in sarcoidosis, as you know, which is a multisystemic granulomatous disease, a non-caseating granulomatous inflammation involving your lungs, involving your skin and your eye as well, and many other parts of the body. The ocular manifestations, as this picture is given by Kansky classically describes this. You have this classic bilateral granulomatous pan-uveitis picture. But what I would like to point to is something which is not being routinely discussed in your classes. The most common orbital involvement is lacrimal gland, right? That's very important thing to know. Sarcoid can involve your lacrimal gland. Okay, it is the most common involvement in the orbit. And the patients can often present this S-shaped ptosis. It looks like an S, right? Because you have the lacrimal gland here, and there you have the something similar to dacroadenitis. This is one of the differentials of dacroadenitis, right? And you can see when you open up, you can see sarcoid granuloma there. Yeah. So always suspect sarcoidosis, a patient presenting with any lacrimal gland swelling. Think of sarcoid, take a serum ACE and do an imaging to rule out anything sinister as well. Good. Now we have finished the sarcoid in brief, right? But what's more important is this, which is the granulomatosis with polyangiitis or vaginous granulomatosis, which is a systemic emergency, which is a vasculitic emergency. As you know, given from this wonderful table from AAO, where you can see among the list of vasculitis, the vaginous granulomatosis, which was formerly known as, features under the small vessel vasculitis. So GPA is a small vessel vasculitis with a triad of three things: vasculitis by itself, necrotizing granulomatous inflammation involving the upper respiratory tract and the lower respiratory tract, and glomerulonephritis. So this is going to be the triad of vaginous granulomatosis. How do they impact in the eye? As you all know, commonly vaginous granulomatosis is going to affect the sclera. So it's going to be one of the reasons why someone can have a scleritis. And that's why when you see a patient with scleritis, you want to do an ANCA workup. You want to do immunological workup because of that reason. But what's more important is to understand is 50% of patients with GPA can have orbital inflammation, right? So a patient presenting with a painful proptosis, double vision with a renal or respiratory signs, always, please make sure that you rule out your GPA. Yeah, this is a patient who's having this painful proptosis, and you take a CT which shows this picture, infiltration of substances into the orbit. Yeah? And this is what is going to cause this proptosis. The granulomatous inflammation is going to cause this proptosis. So that's with the orbital inflammation. It's very important when it comes to GPA. And as you already know, that the classic feature of scleritis in GPA is going to be a necrotizing scleritis. right? A necrotizing scleritis. Scleromalacia perforans is different. That happens in a little white eye that is common with rheumatoid arthritis. This is a necrotizing scleritis, and it also is an associated peripheral ulcerative keratitis as well. So it's a very important thing to have in mind is this GPA causing a very bad, very destructive scleritis and PUK. And this is another picture showing the same. You can see this necrotizing scleritis. You can see pulmonary infiltrates and these giant cells on the biopsy. And this is the necrotizing scleritis, again, responding well with systemic treatment. So this is before and this is after treatment. So far, we have finished the systemic inflammation part, sarcoid and GPA. Next, let's look at the infection. The classic infection is tuberculosis. And again, I won't go into this deeper because there's going to be a separate session just on ocular TB. And you know the systemic manifestation of TB as well. But just to give in brief, TB can involve any part of the eye, right? And any part of the body except the hair, I think. And this is a very useful way to put on your exams the various involvement of the TB in the eye, right? This is what the examiners would be impressed by. When they see like a picture like this, they know that, okay, I mean, it's just the same way of representing in points, but it's a more interactive way, more better way of kind of presenting this. As you all know, TB loves choroid. So people will discuss about TB, but what they may not talk about is the atypical mycobacteria or the non-tuberculous mycobacteria. So what's important with this is atypical mycobacteria can also involve the lungs and they can also involve the eye. The most common tissue involved by the TB bacteria in the eye is going to be choroid, but the most common tissue involved by this atypical mycobacteria is going to be cornea. And in cornea, you would see this stromal infiltrates with these radial projections, what is classically described as a cracked windshield appearance. So you just have this in mind when you put in your exams. You also have this when you have when you're seeing a patient who's having atypical mycobacterial infection in the lungs and look at the cornea, you find this that kind of correlates with what you're saying. So we finished the infection part of it. Let's look at the genetic part, the genetic lung diseases, which can cause eye problems. Cystic fibrosis is not just the lungs, it's a systemic genetic condition, something which you might have read when we were doing our medical school during a pathology. Cystic fibrosis is not really well taught or well kind of discussed in ophthalmology, but this is one of the most common genetic diseases outside. It's most common disease in Caucasians. And if you can recollect your basics in the past, cystic fibrosis basically means that the CFTR gene, the cystic fibrosis transmembrane conductance regulator gene, goes for this mutation, right? And it is an autosomal recessive condition. So what happens because of this mutation is that there's going to be a problem in the transport of ions. So the sodium chloride and bicarbonate does not get transported well, as a result of which the secretions in the trachea and the bronchi, what happens is they become viscous, they become thick, right? So they have a thick, viscous secretion. Because of that, is going to have respiratory distress in these patients. And not just that, along with it, they can also have this secondary pancreatic insufficiency, which is very important, from our perspective. Because of this insufficiency in the pancreas, what happens is that there's going to be reduction in insulin secretion. And diabetes mellitus, called as CFRD, cystic fibrosis related diabetes, is a very unique entity, which is different from a type 1 and type 2 diabetes, right? And these patients, because of this insufficiency of pancreas, can also suffer from vitamin A deficiency, malabsorption syndromes. And this malabsorption is again important from an eye perspective. Think why? Because this vitamin deficiency can lead on to xerophthalmia, dry eye disease. They can also lead on to nyctalopia. So let's look at the ocular. As I said, the deficiency of vitamin A can lead on to xerophthalmia, which is the most common manifestation of cystic fibrosis in the eye. It's just dry eyes, nyctalopia or night blindness. Treatment related. It's again a very useful recent advance. The treatment given for the cystic fibrosis, you have a drug called ivacaftor, right? And this ivacaftor has been shown to cause an adverse effect of causing acquired cataracts in patients. So this is CFTR modulator therapy called ivacaftor can lead on to iatrogenic cataracts. So have that in mind. So it's good, it's good to put these things, because when you see a patient with cystic fibrosis in your multi-specialty hospital practice, and then always think what drug they are on and look for any lenticular opacities. Okay, so we have finished the systemic inflammation of the lungs, infections, genetics. Now let's look at the local causes, just the lungs, the classic asthma. So asthma, like I mentioned, you can have these allergic problems called allergic diathesis, and that can lead on to allergic conjunctivitis and dry disease. What is not discussed much is COPD, obstructive sleep apnea. So as you know, COPD is going to be a chronic obstructive pulmonary disease. And this is going to be a very, very bad thing to have for the patients, because patients generally suffer with this shortness of breath. The lung does not expand much. There's going to be a hypoxemia. There's going to be a reduced oxygen. There's increased carbon dioxide. And because of this, going to be a secondary erythrocytosis, which means that there's going to be increase in the RBC production, which is relevant to us, because when you have this hypoxemia, when you have this hypercapnia, you have this hyperviscosity syndrome happening, which makes the blood vessels prone for thrombosis. So now you know what are the eye manifestations. Yes, you're right. Patients can have a vein occlusion in the fundus, the retina. Speaking of which, the ocular, they say patients with COPD can often have this kind of like a called frog-like faces, because the face they can have puffed, swelling, having a cyanotic appearance called as the frog-like faces, which you might have read during your medical school. And on the posterior pole, like I said, the patients can have these venous tortuosities, they can have retinal vein occlusions, and there has also been studies have shown, case reports have shown presence of disc edema in COPD as well, all because of these factors. Patients having hypoxia, hypercapnia, and secondary erythrocytosis. Now, obstructive sleep apnea. So we all know obstructive sleep apnea. We often discuss this when it comes to NAAION, non-arthritic ischemic optic neuropathy. But let's take it one by one. One of the very important things to understand is that the most common manifestation of obstructive sleep apnea in the eyes is floppy eyelid syndrome. Again, this was not taught to me when I was a resident. I'm not sure how things might have changed now, but what happens because of this obstructive sleep apnea, patients have this increased laxity of the upper lids, and these laxity of the upper lips cause the lids to kind of roll by themselves, kind of evert by themselves. And when the patient is going to go for sleep, it kind of rubs, so the conjunctiva kind of rubs against the pillows, causing chronic irritation, okay? Chronic ocular irritation. That's what this floppy eyelid syndrome can cause. So always be aware of this. And the treatment for OSA is going to be a CPAP, and similar to the mask-associated dry disease, an improperly fit CPAP can lead to dry eyes as well. Like I said, NAAION is an important consideration, and glaucoma can also be one of the important conditions which is associated with OSA. Why? Because of hypoxemia. Because of the reduced oxygen supply, the optic disc can suffer from ischemia, and because of this hypoxemia, that can dysregulate the ocular blood flow to the optic disc, and because of this poor blood flow, and that patients can be at risk for glaucoma as well. And there has been studies which have said papilledema was also seen. In fact, you will see many obese patients having obstructive sleep apnea. So always have that in differentials. Patient having a papilledema in the absence of valid signs of IIH. Okay, always think of OSA being another risk factor. As you all know, patient does not go for sleep properly, because OSA is basically going to lead to loss of sleep. It's a sleep disturbance, and a sleep disturbance patients, the classic central serous chorioretinopathy. This is a very interesting thing which I saw in the recent American Academy of Ophthalmology book, where they said that patients with untreated OSA had a poor response to anti-VEGF. Very interesting. And they found that when they treated the OSA, the patients responded well to the anti-VEGF, which is really interesting to know from a retina person's perspective. Treatment related. So now what we have discussed is we have discussed about the local causes of the respiratory diseases which cause the eye problems. Now we move to the treatment related, which is very easy to understand. As you all know that we give steroids for patients who are having asthma, and inhalational steroids can lead on to post-subcapsular cataract. And does it cause a secondary increase in IOP? It's still a kind of a controversial thing. So yeah, maybe you can just mention that there's always a risk for that. What was really interesting to know is that patients also receive anticholinergics as a treatment of asthma. And this anticholinergics is opposite of parasympathetics, right? So they can dilate the pupil. They're like bronchodilator. So they also dilate the pupils. And you know that anything which dilates the pupil, you have this risk of having angle closure glaucoma. Right? So ipratropium bromide can lead on to a pupil dilatation, which can put the patient at risk for angle closure glaucoma. And you have studies, case reports indicating that as well. And the classic is that you should never give timolol eye drops, which you normally give in glaucoma. You don't give that in asthma or COPD patients because of the risk of bronchoconstriction. So you don't constrict already constricted airways. So that's it with the respiratory diseases. I hope this was clear. So again, my goal is not to talk about every disease in detail, but rather just kind of give those relevant, useful pointers, which otherwise not well discussed when they discuss about the individual diseases. Moving on to the GI diseases, the extra-intestinal manifestation. So when I went through the papers of the eye involvement in GI diseases, one of the very commonly recurring term is EIM, just extra-intestinal manifestation, right? So always make sure you put that word in your exams as well. So there are three subtopics under this: inflammatory bowel disease, infective problems, and genetic problems, something similar to your respiratory troubles. Inflammatory bowel disease, as you all know, the ulcerative colitis and the Crohn's disease, right? And you know what they cause, and they cause uveitis. But what's more important is to understand is this. You see, a patient having an inflammatory bowel disease, like I showed in the previous picture when I discussed about the basic principles, there is a breach in the blood-intestinal barrier. That's the very important term to understand. And patients who are having HLA-B27 positive, they're more at risk of developing uveitis, right? That's why you have this HLA-B27 associated anterior uveitis, and you find ankylosing spondylitis, you find a Reiter syndrome, and you also find your inflammatory bowel disease, or called enteropathic uveitis. You have that. So have HLA-B27 in mind. So if someone asks you, what is the most common manifestation, most common eye problem in a patient with inflammatory bowel disease? I know the gut instinct, no pun intended, would be to go towards uveitis, but no. The most common extra-intestinal manifestation in the eye is going to be episcleritis. So almost 30% of patients have episcleritis. Have that in mind. Okay. I didn't know about this either. And most important thing is this episcleritis is a marker of disease activity. That's even more interesting. So not only episcleritis is going to be the most common ocular manifestation of inflammatory bowel disease, but it is also going to be a very useful marker of disease activity. Contrary to uveitis, right? Where though you have a strong HLA-B27 association, the uveitis is independent of bowel disease activity. Right? So when someone has an episcleritis and IBD, then you know that there is a big relation between them. Oh my God, his episcleritis is going to be more, which means the disease is active, right? The bowel disease is active. But when someone has a uveitis and IBD, you don't really think of an activity of the bowel disease. You can have uveitis when the bowel disease is in remission as well. Sometimes you can have uveitis as a very early marker of a future inflammatory bowel disease as well. Scleritis is very uncommon, yeah, but though you can have scleritis as well. And treatment rated, as you know, steroids So this is always interesting because you always have some point to add, because almost all these autoimmune diseases, you give steroids, and now you know that because of steroids, you have some eye adverse effects on the ocular structures, so like cataracts. So we finished inflammatory bowel disease. Hope that's clear. Now moving on to the infective pathology. There's one infection which I want to point to. It's called a Whipple's disease. Again, this is something which you might have read during your medical school. And Whipple's disease is going to be another chronic disease, chronic condition involving the gut, caused by this bacterium called as Trophoreima whipplei. Yeah, that's the name of the bacteria. It's quite a mouthful. But it can cause ocular problems. So in the eye, what they do is it can cause uveitis. But this is a very interesting thing. It causes a condition, a very pathognomonic sign called as oculomasticatory myorrhythmia, which is a pathognomonic sign of a CNS Whipple's disease, right? So this is one of the ocular manifestations of Whipple's disease. And you find this, that means the CNS can be involved in Whipple's. So what is this? It's basically nothing but oscillations of the eye, a divergent and convergent oscillations of the eyes, which is in synchronization with the chewing muscles. When you chew, you see the oscillations. Just to show a quick video of that condition. As you can see that as the mouth is moving, you can see the eyeball is diverging and converging, right? Yeah. This is classic of a CNS Whipple's disease, and this is called as an oculomasticatory myorrhythmia. Good. So I think an examiner will be really impressed if you want to put this word, and if you find this
resources, YouTube video.
Sorry, that's not autoplay. Right. Good. So now that ends with the Whipple's disease. Now let's go for the genetic conditions. When it comes to genetic conditions, what I have in mind is this: the genetic GIT problems. The most important is the familial adenomatous polyposis. And when this familial adenomatous polyposis, as the name implies, it's an inherited condition. It leads to polyps in your colon. And when you have this FAP, and when you have an extra intestinal manifestation alongside, and that's what we call as a Gardner syndrome. So Gardner syndrome is basically a variant of familial adenomatous polyposis. And in Gardner syndrome is what you would see a very common ocular manifestation, and that is bilateral multifocal chirpy or congenital hereditary retinal congenital hypertrophy, of the retinal pigmentary epithelium. And this chirpy is the earliest clinical indicator of Gardner syndrome, right? As you can see in this picture, that's the bowel showing these multiple polyps. And it's an autosomal dominant condition, and the mutation is the APC gene mutation. And if you can recollect, Gardner syndrome can be a precancerous lesion or a cancer predisposition syndrome. The bilateral multifocal chirpy, like I said, is the earliest clinical indicator. And this is one picture of chirpy, and this is the classic bear track sign, what you see here, where you have one lesion and you have these satellite lesions, and those satellite lesions can kind of lose its color, so it looks like a bear track or an animal footprint sign. But what's important to understand is the chirpy in Gardner syndrome is kind of different from the benign chirpies what you normally see. So I see chirpies almost every week because the opticians here at Moorfiels, their patients, they refer them to our retina clinics. But when you have suspect Gardner syndromes, you would see these bilateral multifocal chirpies. They often be in multiple quadrants, and they have this unique shape of being a pisiform, like a fish-like shape with these irregular borders. So this is going to be a unique, interesting morphological differences you would see in chirpy if someone have a Gardner syndrome. Lastly is the Wilson's disease. So as you know, Wilson's disease is called hepatolenticular degeneration, is involving the liver, and the lens, right? Not the lens, but rather it involves the brain. Where the copper accumulation in tissues, and Wilson's disease classically has this Kaiser-Fleischer ring, which is nothing but copper deposition in the Descemet's membrane at the level, at the level of Descemet's membrane, and it's going to have this circular ring around the limbus. And you can see in this very interesting picture that contributed by my friend, you can see in the deeper layer of the slit lamp, you see that shine, and that's the copper deposition on the Descemet's membrane. So that's the KF ring. The importance of this KF ring is that it is in 95% of neuro-Wilson. So any neurological problem with Wilson's, right? You see a KF, that means that the patient needs a CNS evaluation. That's the take-home point when it comes to this Wilson's disease. And also you have this sunflower cataract, is another manifestation in the eye because of Wilson's. And you see these deposits, basically copper deposits on the anterior lens capsule, what you call as a sunflower cataract. What is a pseudo KF ring? So just a good, goes all the way down, but yeah, that's your pseudo KF ring or a false KF ring. A patient who's going to have an intraocular foreign body which is copper in nature, and patients can have a similar KF ring, right? And also any secondary diseases like secondary copper deposits, liver failure, liver diseases can also have this false KF ring. So just need to have that in mind when you look for these KF rings. So I think we have come to the end of this discussion. I know it's a very short topic, not the conventional 1-hour lectures what we have with iFocus, but the goal of this class is to keep it as simple as possible to enable postgraduates to easily reproduce the concepts in your exams, and also to demonstrate some recent advances such as the eye-lung axis and the gut-eye axis, which are useful things to have in mind. And again, it reinforces the fact that eye is always a part of the body. It's important to get a complete history from the patient. It's very important. And this topic is just kind of re-emphasizes that fact. So I hope this was useful. I'll be happy to take any questions if you guys want.
Yeah. Thank you, sir. So definitely it was a comprehensive coverage for your topic, and especially the way you covered it in a mind map kind of manner was completely different and very, very useful and interactive as well. Thank you so much. So we have a couple of questions. So to begin with, in uveitis, usually we always order, a panel of investigations, right? So in case when we see an isolated granulomatous uveitis, okay, so how often do we recommend HRCT thorax or serum ACE just to rule out the subclinical or, pulmonary sarcoidosis?
Right. So when you say unilateral granulomatous anteruveitis, right? And when you have a granulomatous problem, if it's non-granulomatous, you don't have to order an investigation at the very first episode. If it's going to be granulomatous, which means it's going to be more chronic, and the classic differentials would be sarcoid and TB. So as a basic protocol, we do order serum ACE for sure. Right, along with your full blood count, we order a serum ACE, and we also have this interleukin-2 receptor, which is a new thing, which we don't normally do that back home, but in UK they do suggest to use that. So IL-2R antibodies that has to be picked up. And we don't usually recommend HRCT at the very first instant unless you clinically suspect of pulmonary sarcoid, unless you have the systemic history of breathlessness. Yeah. So I think it's okay to order blood tests, serum ACE, serum calcium, and the other uveitis workup along with MANTO. But in other parts of the world, they order quantiferon TB gold. So you need to work up for that. But I would reserve, get a chest X-ray. But a HRCT might not be needed at the very first instant. But of course, the protocols differ in different institutes. There will be some places who will straight away order everything, but yeah, but not in a typical Indian scenario, I would think.
All right. Okay. So you also mentioned like inflammatory bowel disease, even if there is a GI remission, still ocular manifestations can be there. So in that case, how do you decide between, you'll just go ahead with topical therapy, or should you really, even if there is GI remission, should you start on systemic immunosuppression or biologicals? Like, how do you actually triage?
Now, as far as the IBD is concerned, I would leave to the gastroenterologist to decide on the treatment of the IBD part. And I would just treat the antiuveitis just with topical steroids, because I know that IBD does not cause a pan-uveitis or something like a deeper involvement for me to start on systemic steroids. So it's another important thing to have for postgraduates in mind. The treatment of uveitis gets decided upon the involvement in the eye. And unless it's a scleritis where you start on systemic immunosuppression, or unless it's going to be a posterior kind of pan uveitis, then I would not reserve any systemic steroids or systemic biologics for treating just the anterior manifestations of IBD.
Okay. All right. So another question related to HLA-B27. So when do we actually recommend that, okay, so this has to be tested? And,
Yeah.
is there any influence on the long-term management of the related conditions?
Yeah, it's a very good question actually, because I can see a difference, because HLA-B27 was not really ordered at the very first instance when I was working in Aravind, because of obvious reasons, because of the cost and lots of factors come into play when you want to order. But in UK they do ask for HLA-B27 in patients where you suspect ankylosing spondylitis. But if it's going to be inflammatory bowel disease, and we usually don't really at the very first instance again. But I know a few centers who straight away order HLA-B27 as a routine investigations of any antiuveitis, right? So from an exam perspective, I would put it on there. I would just mention you would test for HLA-B27 if it's going to be recurrent problems or if you have a history associated, but otherwise no.
Okay. All right. So in case after you have started on systemic steroids also for the extraintestinal manifestations as well, and the patient turns out to be a steroid responder, so how do we manage further? Like, in other words, like what are the alternative treatment strategies available?
Right. So just to confirm, the question is that a patient is having an IBD and they have an antiuveitis, and you're starting on topical steroids, and they get a steroid response, and how do you manage that?
Yeah.
Is that the question?
Otherwise, the other scenario would be they are on systemic steroids.
Systemic steroids patients, at least I don't see much of an intraocular pressure rise, but what we commonly see is the topical steroids causing a secondary glaucomatous response. It's a very common problem because when you see a patient with a for your exams, or if you're gonna be all by yourself in a practice, and you've started a patient on a topical steroids, you see a steroid response, there is no harm in starting anti-glaucoma therapy. Right. And here the protocols at Moorfiels is that if the pressure is going to be above 40, we give Diamox 250 milligrams or 5 milligrams stat, as long as no renal contraindications. And we give a stat dose of Cosopt, which is a combination of timolol and dorzolamide. We give that. We give iopidine, which is upra-clonidine drops, and also we give monopost. So we give all these 3 drops along with this tablet as well, stat dose. And then we usually start with monotherapy or kind of dual therapy as well. And we monitor from then onwards. But we never kind of sacrifice the topical steroids in view of the pressures, because the pressures can always be controlled. But what's more important is to keep the inflammation under control, because the inflammation can also cause a secondary pressure response. You can have trabeculitis as well. So you should see why you have increase in the eye pressure. Is it because of your steroids, or is it because of inflammation? That's something which you have to have in mind.
Okay. All right. Okay. So in with relation to the KF ring, So in case if we start them on chelation, does it always resolve, or like how is the response usually?
So to be honest, I've never seen a KF ring. Maybe I might have seen when I was a medical student, I think, but otherwise I've not seen a KF. So I've not managed a KF ring by myself. It's again one of the reasons, when you work in just an eye hospital, you don't see such patients often, right? But I'm not sure about that aspect. Maybe I can get back to you and put it on the comment box.
No problem. So, yeah, the last question would be, so when do we actually refer a patient to a pulmonologist or a gastroenterologist? So in other words, what are the red flag signs, or when do we suspect, okay, so now I think, we'll have to refer. So when do you think we should do that?
So like I mentioned, one thing to have in mind is GPA, the granulomatosis polyangiitis or vaginous granulomatosis, which is an emergency, right? And that warrants an immediate referral. So any urgent vasculitis, you do a systemic workup. It's important to refer the patient to a rheumatologist in the first place. And when you feel there is other systemic symptoms or signs, and then you refer to the respective specialists. Again, it all boils down to where you are practicing. If you have the luxury of having a gastroenterologist next door, then why not, right? But in other parts of the world, in NHS, where you don't have that luxury, right, the patient have to wait for a very long time, then it becomes a bit difficult for us to kind of refer. But as you might have got a sense, any patients who's going to have, say, for example, you're going to find an ocular TP, and that means that you have to refer the patient to a pulmonologist, right? Or infectious disease specialist. Sarcoid is the same. GPA is going to be the same. So there's no harm, but when you have a strong suspicion, you can make an urgent referral.
Yeah. So are there any specific, excuse me, ocular manifestations do we look for before referring to a gastroenterologist, like anything like retinal vasculitis or anything at all? Like, how do we decide apart from?
Yeah. So, I mean, you would not really kind of link that ocular problem because you see the eyes first, and we presume the patients don't have a background or a previously diagnosed GI problem. Then you see the patients first time, and you don't really think of IBD. You don't really think of that, right? Because the most common cause of an anteruveitis is going to be idiopathic. You just treat that. And only when it's kind of recurring, and only when you see the systemic signs associated, symptoms associated, that's where history is important, and that's when you refer. Otherwise, I wouldn't think there is, because I understand your question. Is there very kind of unique features which makes us to refer the patient to that? I'm not sure. Maybe uveitis experts will have better answers where they find something very, very specific about that uveitis, which makes them to refer to that because they know the systemic cause of that could be that. But as you know, for example, in sarcoid, you have this mutton fat KPs, as in TB, you have this broad-based posterior synec, lacrimal gland involvement. You would suspect a lacrimal gland involvement in TB commonly, but sarcoid is much more common. So these are subtle signs which makes me think towards, okay, this could be something more specific towards one systemic condition, and that's when you make the referral to the specialist ongoing.
Yeah. All right. So I think I'll end the question and answer session with that. Thank you so much. So before we end the session, I would just like to remind all our viewers and the other postgraduates who will be watching it later. So we still have very limited slots available for iFocus 2025, this time in New Delhi from August 10th to 17th. And it's the national postgraduate education program that you don't want to really miss. Okay. So the next class will be on 25th of July, which is Friday, on ocular toxicity from systemic drugs by Dr. Richa. So thank you so much, Dr. Pranesh, for joining us. It was really an honor to have you. And thank you. Yeah. Good night.
Thank you so much. Take care. Bye-bye.